Okay, so now we are starting with neonatology. That is, first topic will be neonatal sepsis. So it will be discussed under following, that is definition, classification, pathophysiology, clinical features, investigations, and treatment. So why it is important to know about sepsis, septicemia in neonate? Because it causes higher mortality in neonates. So common terminology that is usually overlapped are septicemia and sepsis. Sepsis, local septicemia, it is the infection in blood. Sepsis, it is the systemic inflammation due to infection, and severe sepsis, it is sepsis plus organ failure and septic shock, it is with hypotension. So infection in neonates, it is superficial infection, it can be systemic infection. So if it is a systemic infection, we call it neonatal sepsis. So it is clinical syndrome characterized by signs and symptoms of infection with or without accompanying bacteremia in the first month of life. It encompasses various systemic infections. Superficial infection like conjunctivitis, oral thrush are not usually included in neonatal sepsis. So if we talk about the causative organisms, among intramural births, that is inborn births, it is usually Klebsiella pneumoniae, more frequently followed by Staph aureus. Among outborn births, newborns, it is usually again Klebsiella pneumoniae with Staph aureus and followed by Pseudomonas. Sepsis can be early onset or late onset depending on the onset. If it is less than 72 hours of onset, then it is early. Otherwise, it is late onset. So risk factors for early onset of sepsis, it is low birth weight, febrile illness in the mother, foul smelling or meconium stained liquor, rupture of membrane more than 24 hours, unclean vaginal examination, prolonged labor more than 24 hours, perinatal asphyxia. Factors that might increase the risk of community-acquired late onset sepsis are low birth weight, prematurity, admission in intensive care unit, mechanical ventilation, any invasive procedures, administration of parenteral fluids, poor hygiene, poor cord care, bottle feeding, or prelacteal feeds like honey. In contrast, breastfeeding helps in prevention of infection. So sepsis pathology, if we talk about, there can be vascular. Any infectious agent leads to stimulation of hormones, cytokines, and enzymes. They all come into play, leading to the stimulation of immune system, coagulation system, endothelial damage, and leading to sepsis syndrome. There will be vascular leak in the tissue damage, leading to decreased flow in the small vessels, compromising the circulation, deposition of fibrin-rich thrombi in small vessels, again leading to hypoperfusion of the tissue. So bacterial infection can lead to host response, as I have said. It leads to the stimulation of various enzymes and leading to organ damage and death. Clinical features, it can be subtle, or there needs a high index of suspicion for early diagnosis of septicemia. So patient neonate can present with hypothermia or hyperthermia, lethargy, poor cry, refusal to suck. These are the most common symptoms, followed by poor perfusion, hypotonia, bradycardia, tachycardia, hyperglycemia, metabolic acidosis, respiratory distress, apnea, or gasping respiration. In CNS, it can be a bulging anterior fontanelle on examination. A patient may come with seizure, neck retraction, irritability, hypotension, poor perfusion or shock, feeding intolerance or NEC, hepatomegaly, hyperbilirubinemia, ARF, bleeding, petechia purpura, skin changes, mottling. Blood culture, it is the gold standard for the investigation, for the diagnosis of septicemia and neonate. Meningitis, to rule out meningitis, lumbar puncture is done and CSF is sent for culture and sensitivity and routine microscopy. So this is the practical sepsis screening in a neonate where we see TLC counts, absolute neutrophil counts, micro ESR, immature to total neutrophil, that is band cell, C-reactive protein more than 1 milligram per deciliter. Apart from blood culture and sepsis screening, we can go for radiology. If there is signs of infection of chest or abdomen, NEC or pneumonia, urine culture, CT scan, management can be supportive and antimicrobial. We have to keep the thermoneutral environment to prevent hypothermia, oxygen saturation. We have to maintain hemodynamical unstable. If the child is, you have to give IV fluids, monitor hypoglycemia. You have to give inotropes or transfusions accordingly. If meningitis, the treatment duration is 21 days. Blood culture positive with no meningitis, 14 days. And if there is probable sepsis, then 5 to 7 days of parenteral antibiotics. Indication for starting antibiotics in early onset sepsis. If there is a presence of more than 3 risk factors for early onset sepsis, presence of foul smelling liquor, a strong suspicion of sepsis or any other risk factors, and positive sepsis screening. Indication for starting antibiotic in late onset sepsis, again positive sepsis screening, or if there is suspicion. We do not use prophylactic antibiotics in the following circumstances, though the main management in septicemia is antibiotics, but prophylactic antibiotics should not be used to avoid resistance in the future. So in infants on IV fluids or routinely TPN exchange transfusion you are doing, then routinely prophylactic antibiotics are not given. So the antibiotics that are given, first line is penicillin, ampicillin. If there is meningitis, add Taxim, as it can cross the blood-brain barrier nicely. Second line, again gentamicin, amikacin you can add. Third line, you can go for piperacillin, tazobactam, ciprofloxacin, amikacin, and Taxim. Reserve antibiotics are aztreonam, meropenem, and imipenem. Adjunctive therapy apart from antibiotic can be exchange transfusion in severe sepsis if there is development of scleroderma. IVIG has good role. Granulocyte macrophage colony stimulating factor can be given. So, to summarize, empirical use of these antibiotics should be avoided. They should be reserved for situation where sensitivity of the isolated organism warrants in its use. So, in a nutshell, neonatal septicemia is a systemic infection and important cause of neonatal mortality, especially in developing countries. If severe, it can lead to multi-organ damage. Any dull neonate coming to OPD should be evaluated for sepsis. Klebsiella is the most common organism in both inborn and outborn neonates. Antibiotic remain mainstay of treatment along with supportive care. So at the end of the lecture, you should know classification, etiology, signs and symptoms, and management. So coming to another and winding up these with important topic, that is NRP guidelines, neonatal resuscitation program. So what it is neonatal resuscitation is intervention after a baby is born to help him breathe and to help him beat, okay, heartbeat. Because before a baby is born, the placenta provides, we all know, provides oxygen, nutrition to the blood and removes carbon dioxide. After a baby is born, the lungs take over the function. The transition from using the placenta to using the lungs for gas exchange begins when the umbilical cord is clamped or tied off and the baby has its first breath. So these guidelines apply primarily to newly born infant transitioning from intrauterine to extrauterine life. The recommendations are also applicable to neonates who have completed newborn transition and require resuscitation during the first week of life. So ventilation of the lung is the most important and effective step in cardiopulmonary resuscitation of a compromised newborn. So in NRP, the golden minute, the first 60 seconds of life of a born newborn is very important for completing the initial step, re-evaluation and beginning the ventilation if it is required. So it is important to avoid unnecessary delay in the initiation of ventilation because this is the most important step for successful resuscitation of the newborn who has not responded to the initial steps. The decision to progress beyond the initial steps is determined by simultaneous assessment of the vital characteristic, that is respiration in the form of apnea, gasping or unlabored breathing, and heart rate if it is less than 100 per minute. So approximately 10% of newborn requires some assistance to begin breathing at birth and only 1% require ventilation or chest compression or medication. So what are the conditions that require resuscitation? So it can be maternal condition, it can be postnatal condition related to the newborn. So in maternal condition, it can be diabetes, mellitus, hypertension, any maternal illness of heart, lung and kidney, history of previous stillbirth or miscarriages, early neonatal death, premature rupture of membrane, infections like UTI, GBS carrier, placental anomalies and heavy sedation. Fetal condition, macrosomia, congenital anomalies, IUGR, pre or post maturity, hydrocephalus, multiple gestation, abnormalities of the presentation. During birth, prolapse called utero-placental bleeding, prolonged labor, meconium in the amniotic fluid, abnormal fetal heart rate pattern, instrumental deliveries. So what are the preparation that should be made before starting resuscitation? First, determine the team. Determine the leader, clarify the role, responsibility, and delegate tasks. Perform a standardized equipment check. So these are the equipments required. First question we have to ask: term gestation, good tone, breathing, or crying. If this is yes, we have to take the baby for the rooming in with the mother, maintain him warm. If this is the answer is no for all the three questions, then initial steps in stabilization should be used: normal temperature, position, clear the airway, ventilate and oxygenate, initiate chest compression, and administer epinephrine if required. So positioning of the neonate, there should be no hyperextension or flexion extreme. This is the right position with slight head tilt and chin lift. So this is the algorithm. If the baby's term tone is good and breathing or crying, then you have to shift the baby to the mother's side. If the answer is no, you have to warm the baby, maintain the airway, and secretions are there, you have to remove that secretion. And still, if there is apnea, gasping, or labor breathing, you have to shift the neonate to CPAP, assisted ventilation, go for positive pressure ventilation, monitor with SpO2 and ECG. If the heart rate is below 100, then you have to go for the ventilation corrective steps. And if it is still below 60, then you have to go for the chest compression. And still below 60, then you have to go for epinephrine. So chest compression, it is given by 2-thumb technique. 100% oxygen is given. 1, 2, 3, and breathe. 60 seconds. This is the technique. After every step, you have to go for the corrective step, whether the mask is adjusted properly, repositioning of the airway, suction of the mouth and nose, open mouth, pressure increase, alternative airway. This is MR SOPA. You have to go after each step to see this, to take this corrective steps if the chest is not elevating. So don't say newborn resuscitation. There should not be rigorous suctioning, beating of the baby, slapping the baby, suction and pus, then मतलब nose को पहले suction कर दिया, mouth को बाद में कर दिया. There should be suction of the mouth first, then the nose. Adequate pressure around the rib to avoid damage. Do not dilate anal sphincter. Blow your lungs into mouth of neonate to avoid infections. Avoid sedation to the mother. Prevent hypothermia. So ethics and care at the end of the life. If possible, physician believe that the baby has no chance of survival, initiation of resuscitation, not an ethical treatment option, should not be offered. But a confirmed gestational age of less than 22 weeks of gestation, or with severe congenital malformation or chromosomal abnormality. Usually resuscitation is, it was done for 10 minutes before declaring the baby. Before declaring the baby certified, before certifying the baby. Now, but nowadays it is done for 20 minutes before certifying the baby. That's all. Thank you.